స్టార్ట్ చేశారా మీరు? మరి ఇక్కడ రావట్లేదు. ఓకే 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 ఫైన్. Okay, hello. Today, Inakshi ma'am is not available today, so I am taking the class on her behalf. I am late. Okay, let's see. 11 members in the class. Let's see how many will be left by the end. Okay, today we'll be seeing malaria treatment and control. Uh, okay, I'll just. Okay, control. So the strategies for prevention and control of malaria and its transmission are surveillance and case management, which includes case detection, passive and active, early diagnosis and complete treatment, and sentinel surveillance. Now surveillance and case management is important because, as we know, surveillance means we are trying to find out cases in the community. Okay, and case management is, as all we know, that we have to treat the cases, not only finding the cases, but we have to know the treatment so that the transmission of the virus or the a fever or whatever will be reduced. So like that we'll be reducing the case load. So in surveillance and case management, we'll get this case detection, which is passive and active. Passive means the cases that we get in the hospital, like they come near us with fever, chills and sweats, or whatever the symptoms of malaria. And active means we'll have to go and find the cases in the community. Next is early diagnosis and complete treatment. Early diagnosis is, yeah, as soon as we are suspicious of a fever, we have to try to get the test done quickly, or we have to try to give the diagnosis as early as possible so that we'll start the treatment. I'll talk about the treatment, how it is in the in given in park textbook, so that it will be easy for you all to memorize. So next is sentinel surveillance. Like we have to, go and, as I told you, I'll go and see the cases outside in the community. Next, and we have to see the, environmental, the surroundings also. Next comes integrated vector management. First is indoor residual spray, insecticide treated bed nets, and long lasting insecticidal nets. Okay. Next are anti larval measures, including source reduction. Mm. Next is epidemic preparedness and early response. Okay. And next is supportive interventions. Under supportive interventions, we have capacity building, like building of, creating a team, and then including health workers or the link workers, what we say, and educating the lab technicians on how to diagnose, how to read the smear, and all that is called capacity building. Next is behavioral change communication. Behavioral change communication is for the people, or like how is health education. Health education and behavioral change communication are two different things. Okay, first, let me tell you all, you guys are now going to give your SPM exams. So health education is, it is an education. Like you go and educate people. Like you tell them about the disease, you tell them about symptoms, you tell how to prevent it, and then you just forget it. You just go back to your routine life. But behavioral change communication is you know, health education plus the follow up. Okay, it's like a follow up of case. Okay, so you do a health education again after 2 months. Again, you go to the community and ask questions and observe how they are. Is there any change like after your education? Like for example, if I take malaria here, you go and educate them about the breeding places of mosquito and the symptoms, and then after 2 months or 1 week or you explain them about dry day, like every per day you have to maintain a dry day in a week, so that the life cycle, eggs, they won't hatch, so you just the eggs will die. There'll be no water for mosquitoes to breed and lay eggs, so one day will be kept for dry day. So you observe all this and then you see whether they are changing in the normal, if there's any change before. So that is behavioral change communication. There are only three members left in the class. I don't know whether to take the class or not, because there's no point of taking the class for two members now. I think I'll just go. I mean, I'll just quit the class, because I don't know whether you guys will listen to the class later or not. How will I know? It's a weekend means like you will not listen to the classes, is it? Weekends are for people who are working or who are into the multinational company, not for us. Okay, Sundays are also working for us. Put that in your mind. With this thinking, you will not be able to sit for your long term preparation of NEET exam. Okay. Okay, just I don't. If you'll have any queries, you can message me in the chat box. I'm constantly seeing the chat box beside. Okay. Next is, I'll just run through. I'm not going to explain anything. This I've brought. I have kept this from Park. Whoever are seeing this, whoever feel that it's a waste of time and you can just go enjoy your weekend. Please feel free. You all can go, and then this is just from Park textbook. You can just go read. Okay. And just I kept this from Park so that you can understand what I'm telling, and then you can read in Park so that you will remember for a longer time. Okay. Next point in supportive interventions are intersectoral collaboration, where you have to communicate with I mean PHCs in your area or other hospitals, where you have want to know the cases of malaria, the treatment, the prognosis of severe malaria cases, all that. Next, monitoring and evaluation. Yes, monitoring and evaluation is very important in any kind of preparedness or any programming or any program management. So where you will monitor how are the cases or how you are um, going in a proper way to understand the caseload or understand the severity of the disease in a community, or the side effects of the drugs. Okay, all that comes under monitoring and evaluation. Next is operational research and applied field research. Okay, this, as you all know, we have to keep on doing some research so that we'll understand the problems in that area. Okay. Next, early diagnosis and treatment of malaria aims at complete cure, prevention of progression of uncomplicated malaria to severe disease, prevention of deaths, interruption of transmission, and minimizing risk of selection and spread of drug-resistant malaria parasite. Okay, all these you can write on your own. Okay, coming to the treatment of uncomplicated malaria. Now, all fever cases diagnosed as malaria by microscopy or rapid diagnostic test should promptly be given effective treatment. Okay, coming to the treatment of Plasmodium vivax cases. Positive Vivax cases should be treated with chloroquine in full dose of 25 mg per kg divided over 3 days. Okay, so 25 one day 1 or 25 day 2, 25 day 3. Okay, next Vivax malaria relapses due to the presence of hypnozoites in the liver. The relapse rate in Vivax malaria in India is around 30%. For its prevention, Primaquine may be given at a dose of 0.25 mg per kg daily for 14 days under supervision. Primaquine is contraindicated in G6PD deficient patients, infants, and pregnant women. Okay, now whoever are listening to me in the class, can you all tell me why Primaquine is contraindicated in G6PD deficiency people? Okay, try to, medicine is very interesting. You try to just ask a question why, then you get the answer, and then you apply it to all your subjects. You will remember it for a longer time. Okay, so I would want this is one assignment for you all. It just takes a very less time to find out the answer. I want you all to send me, you all know my mail ID. Send me the answers to my mail ID for this question. Why is Primaquine contraindicated in G6 deficient patient, infants, and pregnant women? Okay, I want the answer. You all can send me next week if you all want to enjoy this weekend. Okay, send me on Monday or Tuesday. Okay, but I want the answers. Next, treatment of falciparum cases. Artemisinin combination therapy or ACT, okay, which is of artesunate 3 days plus sulfadoxine pyrimethamine, which is known as SP, for 1 day, should be given to all confirmed falciparum cases found positive by microscopy or rapid diagnostic test, accompanied by single dose of primaquine, which is 0.75 mg per kg body weight on day 2. Okay. Now, there are few areas in India, like northeastern states, where you find resistance to this sulfadoxine pyrimethamine drug. Yes, sulfadoxine pyrimethamine. Okay, SP drug. So, for those cases, you will be giving artemether of 20 mg plus lumefantrine of 120 mg as per age-specific dose scheduled for the treatment of Plasmodium falciparum cases in northeastern states. This drug is not recommended during the first trimester of pregnancy and for children weighing less than 5 kg. Okay. Next, treatment of malaria and pregnancy. ACT should be given for treatment of Plasmodium falciparum malaria in second and third trimesters of pregnancy, while quinine is recommended in the first trimester. Vivax malaria can be treated with chloroquine. Primaquine is contraindicated in pregnant women. Now, treatment of mixed infections. Mixed infections with Plasmodium falciparum should be treated as falciparum malaria itself. Okay, so remember that. Resistance, mixed infections means you will have, falciparum and other parasites in one patient. So you will have to, any infection with falciparum should be treated as a falciparum malaria case. So resistance should be suspected if, in spite of full treatment with no history of vomiting, diarrhea, patient does not respond within 72 hours clinically and parasitologically. So such cases not responding to ACT should be treated with oral quinine with tetracycline or doxycycline. These instances should be reported to concerned district malaria or state malaria officer for initiation of therapeutic efficacy studies. Okay, understood? Because there's some resistance going on, so you have to report so that they'll understand what is the problem and what is it resistance to. Okay. Next is coming to the diagnosis and treatment of malaria. This is a flowchart from your Park textbook only, and I will try to explain it. Where okay, now you suspected a case and then you took you took a test, and then when microscopy result is available within 24 hours, what do you do in such cases? So you do if you suspect a malaria case, then you take slide and send for microscopy examination. Then you wait for result. For, in that time when you do not know the result, mm, I mean, before, I mean, after, like, depending on the result, sorry, depending on the result, you will know. I mean, if it is positive for Vivax, then you will treat with chloroquine for 3 days plus Primaquine 0.25 mg per kg body weight for 14 days. And if it is positive for falciparum, as I told you, northeastern states, you will have to treat with ACT AL for 3 days and Primaquine single dose on second day. In other states, you have to treat with ACT SP, okay, for 3 days and Primaquine single dose on second day. Remember, it's the same. It is the same over here, where you will have to give lumefantrine. Over here, you'll have to give SP. In other states. Okay, you will give for falciparum, you'll give Primaquine single dose on second day only. For Vivax, you will give Primaquine for 14 days, that 2.25 mg per kg body weight. Okay, so over here it is given ACT-AL means artemisinin based combination therapy and artemether lumefantrine, and ACT and SP. There is sulfadoxine pyrimethamine. Okay, so next, if it is positive for mixed infection, so mixed infection, you will treat them as falciparum cases. Okay, so the same. Can you know the tell me the difference in this? You will have to treat as in northern or northeastern states. You will treat for like ACT-AL for 3 days and Primaquine 0.25 mg per kg body weight for 14 days. Other states you will have to treat with ACT and SP for 3 days and Primaquine 0.5 mg for 14 days. Okay. Okay. The table is telling something and the theory is telling something, huh? Okay. So if it is negative, you will not give any treatment, and but you have to treat as per clinical diagnosis. It may be any other treatment, any other diagnosis. Okay. Yes. When microscopy result is not available within 24 hours and monovalent RDT is used. Now suspected malaria case, then you where TFR is more than 1% and uh, uh, or PF person is more than 30% any of last 3 years, you have to do RDT for detection of malaria and prepare slide. If it is positive for falciparum, the same treatment as I told before. And if it is RDT negative, wait for slide result, give chloroquine 25 mg per kg over 3 days if high suspicion of malaria. Okay. Next, if confirmed as Vivax, give chloroquine. If not already given Primaquine 0.25 mg per kg day over 14 days. Okay, so whatever treatment from this flow chart, whatever the result is, we have to treat start off the patient with chloroquine 25 mg per kg over 3 days. Okay, then after the result, if it is positive, then we will have Primaquine for 14 days, or then we will add. Then we will, if it is positive for falciparum, then you will treat as falciparum cases. In other areas, if patient is not at high risk of falciparum, wait for slide result. Give as I told you, give chloroquine. Only if high suspicion of malaria is there, give chloroquine for 3 days. Then if we get Vivax, then Vivax positive, then you have to continue chloroquine and then start Primaquine. Then if it is positive for falciparum, treat as I told you before, ACT-AL for 3 days, Primaquine on second day. Other states, ACT-SP for 3 days, Primaquine on second day. Next, if where microscopy result is not available within 24 hours and bivalent RDT is used, then in that case you will after suspecting a malaria case, we'll do a blood test with RDT. Then you get positive for Vivax. Just discard the slide and treat as a Vivax case. If it is falciparum, discard the slide and treat as a falciparum. Then if it is positive for mixed infection, treat it like Vivax case. I mean, like falciparum case only, but you will have to add Primaquine like Vivax, like uh, For falciparum, we will add ACT-AL for 3 days, and then primaquine we have to add for 14 days. Okay, and SP-ACT for 3 days and primaquine for 14 days. If it is negative, no malaria treatment, no anti-malaria treatment. Okay. Next 3 members only. Okay. The treatment of Vivax malaria. It is I kept this as a chart. So on day 1, Vivax, as I told you all, we will give chloroquine and primaquine. So on day 1, if it is less than 1 year, chloroquine 150 mg base, you will give half, and primaquine 2.5 mg, 0. We will not give for infants primaquine. I already told you all that. And for pregnancy also, we will not give primaquine. Okay. Okay. Try to keep this. So less than 1 year, we won't give primaquine. Okay, 0, 0, 0, 0. Okay, and pregnancy also 0. Okay, so I hope you all will remember this. We will not give primaquine for infants and pregnant women. Okay, so 1 to 4 years we will give chloroquine 1 on day 1, primaquine 1, same thing, but on day 3 we will give half. On day 4 we will give only primaquine because it is from day 4 to day 14. No, I mean, yeah, primaquine from day 1 to 14, and chloroquine is only for 3 days. So as age increases, we'll be increasing the number of tablets. So 15 years or more, you'll have to get uh, 4 tablets, 6 of primaquine tablets, 6 and 6 and 6. Okay, so this is how it goes. Next, treatment of falciparum malaria. You have colors in this falciparum malaria treatment. You have pink blister where you give 0 to 1 years. And SP sulfadoxine pyrimethamine is not be prescribed to children for children less than 5 months of age and should be treated with alternate ACT. Okay, so over here, um, 0 to 1 you will be giving, instead of SP you will be giving ACT. Okay. So next, ACT-AL is not being prescribed for children weighing less than 5 kg. Okay. Now, next for yellow blister, you get artesunate 1 or 50 mg, and then sulfadoxine pyrimethamine 1, 500 plus 25 mg each. Then on second day, you get 50 mg and then 7.5 mg primaquine. On third day, you will get artesunate. Okay. So remember, primaquine will be given on day 2. Okay, and artesunate SP or ACT and SP, all this will be given for 3 days, right? Am I right? Yeah. So read that and remember, stick it on your walls. Be ready and be thorough. Yes, as I told you all, in northeastern states, ACTL co-formulated tablet of artemether 20 mg and lumefantrine 120 mg. Not recommended during first trimester of pregnancy and for children weighing less than 5 kg. So it goes as this: total dose 5 to 14 kg or more than 5 months to less than 3 years, 20 mg and 120 mg twice daily for 3 days. Yeah, so this goes on, and then this is the number of tablets in packaging. Okay, 6, 12, 18 and 24. Color of pack: yellow, green, red, white. And then you'll have to give primaquine on day 2, 0.75 mg per kg body weight. Okay. Next, the treatment of uncomplicated falciparum cases in pregnancy. In first trimester, you give quinine salt 10 mg per kg 3 times daily for 7 days. Quinine may induce hypoglycemia. Pregnant women should not start taking quinine on an empty stomach and should eat regularly. Second and third trimester, area-specific ACT as per dosage schedule given above, that is ACT-AL in Northeastern, ACT-SP in other states. Alright, are you all able to understand? 4 members are there. At least you all reply whether you all are understanding or not. Next, the treatment of mixed infections, where Vivax and Falciparum. All mixed infections should be treated with full course of ACT and Primaquine, 0.5 mg per kg body weight daily for 14 days. Okay, the same thing I'm repeating again and again so that you all will remember. But after seeing the strength, I am least interest. I'm getting very less interest. Hmm. Okay. Next is dosage chart. The same thing. Okay. Vivaxin, falciparum malaria. So on day 1, day 2, day 3, day 4 to 14, we'll be treating them with artesunate and sulfadoxine, pyrimethamine, and then primaquine. Okay, for till 14 days of primaquine. Like treatment of plasmodium ovale and malariae. In India, these species are very rarely found. So you'll be treating ovale will be treated as Vivax and malaria will be treated as falciparum. Okay, so don't get confused if you get any question in your exam or if any external during a viva will ask these questions. Okay, now coming to the chemotherapy of severe and complicated malaria. Initial parenteral treatment for at least 48 hours. Choose one of the following four options. You will be giving, we'll have to choose. Then in quinine, 20 mg quinine salt per kg body weight on admission, IV infusion or divided IM injection, followed by maintenance dose of 10 mg per kg 8 hourly. Infusion rate should not exceed 5 mg per kg per hour. Loading dose of 20 mg per kg should not be given if the patient has already received quinine. Artesunate 2.4 mg per kg IV or IM given on admission, that will be counted as 0. Then at 12 hours and 24 hours, then once a day. Or RT-mether, where you will give 3.2 mg per kg body weight IM given on admission, then 1.6 mg per kg per day. Or RT-ether, 150 mg daily IM for 3 days in adults only. It's not recommended for children. Now, follow-up of treatment, patient can take oral medication following parenteral treatment. Quinine 10 mg per kg 3 times a day with doxycycline 100 mg once a day or clindamycin in pregnant women and children under 8 years of age to complete 7 days of treatment. Full oral course of area specific ACT. In the same I told. Northern states you will give ACT AL and others ACT SP. Okay. The parenteral treatment in severe malaria cases should be given for a minimum of 24 hours once started, irrespective of the patient's ability to tolerate oral medication earlier than 24 hours. Okay. Did you all understand this? I hope you all understand. And I am not getting any response from you guys. Okay. So uh, okay, these are the toxic hazards of drugs. That means side effects of the drugs that you treat for malaria. So chloroquine has few side effects: nausea, vomiting, blurring of vision, headaches. But they are very mild and transient. Case of retinal damage have been reported. Um, it is important to remember chloroquine should not be given on empty stomach. Okay, and pyrimethamine can be safely taken alone during pregnancy. That is what the studies told. The teratogenic effect of pyrimethamine is not proved in humans. The likely toxic symptoms, which may be of three types, are plasmocyte type, gastrointestinal type, cardiovascular type. Plasmocyte type is rare toxic manifestation involving CNS, gastrointestinal, cramps, nausea, vomiting. That is your favorite answer for any side effect of drug. So cardiovascular, more serious toxic manifestation is to be carefully observed during the administration of the drug. Okay. Hmm. Okay, so the surveillance worker or MPW must carefully check for all possible toxic symptoms before he administers a daily dose of Primaquine. In case of any appearance of any of the toxic symptoms discussed above, Primaquine treatment should be stopped immediately. Next, active intervention measures. Uh, in this stratification of the problem, Malaria is a complex. Okay, I'm coming back to the control of malaria, uh, where it is given under active intervention measures. So malaria is a complex disease, and its distribution and intensity vary from place to place. The stratification of the problem has to become an essential feature of the planning and development of a sound control strategy to maximize utilization of available resources. Okay, so we have to divide the problem according to the areas and know how much is the uh, problem load or in that area. So stratification is nothing but dividing. Okay, next, vector control strategies. Vector control is still one of the primary weapons to control malaria in endemic areas. So the most favorite answer, so I just kept it in a box where you know uh, for individual and family protection, reduction of human mosquito contact, you will have ITN, repellents, protective clothing, these Odomos creams, these all outs, yeah, all these. Next are for community protection, insecticide treated nets, zoo prophylaxis is done. Destruction of adult mosquitoes is not given in this table, but I think you can relate to these mosquito bites that we get. Okay, don't write that, but I'm just trying to give you all some, you know, not common answers, but some different thing. So, community protection, you will have insecticide treatments, indoor acidic spraying, space spraying, ultra low volume sprays, destruction of mosquito larvae, peri-domestic sanitation, and larviciding. In a community, you will have to do larviciding of water surfaces, intermittent irrigations, biological control, and source reduction. In individual and family protection, you will do small scale drainage, and for community participation, environmental sanitation, water management, and drainage. Social participation, motivation for personal and family protection, and health education and community participation. Okay. Now, and just come to the last. Okay, anti-adult measures are residual spraying, where you will like DDT, malathion, phenitrophion, and you do indoor spraying. Then indoor spraying has it will reduce the longevity of the vector, but it should be continuously done. Like in regular intervals. Malathion and fenriathon are organophosphate insecticides which are being used with increasing frequency for malaria control following development of vector resistance to DDT. Now, space application. This is a major anti-epidemic measure in mosquito-borne diseases. It involves application of pesticides in the form of fog or mist using special equipment. Okay, these are called ultra-low volume method. Yeah, so where you will get under pressure, you will get small droplets of the pesticides. And the spraying is something that is like a fog or gas, but over here you will have the droplets of pesticides. Okay, that will be dispersed by air or by ground equipment has proved to be effective and economical. Um, Next is individual protection. You all know all this protective clothing and repellents and coils and okay. Next, anti-larval measures. You have larvicides during the first half. All this is not there. Okay. Previously, we used to use oil, to cut off the oxygen supply for the larvae inside. But now it's not being used. Now, and a Paris green was used before, but again, that also is cost effective, so not being used nowadays. So now model herbicides like Timifos, which confer long effect with low toxicity, are more widely used. Okay, now there's this called the Project No Fever. Okay, going on right now to reduce dengue fever in community. So um, if you all have read newspapers also, like 2 or 3 weeks back, we got a news saying that so and so MLA has released these larvicide fishes into the ponds or something. Timifos is being given into the ponds. Okay, all this is going on in this season because can you all answer me that? Why are we doing all these anti-larval measures or anti-mosquito, breeding sites, all that in this kind of season? Can you all answer me that now? Okay. Because the season, rainy season has gone and after all that water will be, left in some places where it will not be drained properly or not evaporated. So, there are highly chances of mosquito breeding in those places. Like source reduction techniques to reduce mosquito breeding sites, like drainage or filling, deepening of flushing, management of water level, changing salt content of water, irrigation, integrated control. In order to reduce too much dependence on residual insecticides, increasing emphasis is being put on integrated vector control methodology, which includes bioenvironmental and personal protection measure. This approach is important because there is no single and simple method that would ensure control of transmission. Now, coming to the chemoprophylaxis. Chemoprophylaxis is recommended for travelers from non-endemic areas and as a short-term measure for soldiers, police, and labor forces serving in highly endemic areas. Chemoprophylaxis should be complemented by personal protection where feasible and by other methods of vector control. Now, it can be given less than 6 weeks and more than 6 weeks. Okay, less than 6 weeks, dosing schedules for children should be based on body weight. Antimalarials should be taken daily. Like example, doxycycline should be started the day before arrival in the risk area. Weekly fluoroquine should be started 1 week before arrival. Weekly mefloquine should preferably be started 2-3 weeks before departure to achieve higher pre-travel blood level and to allow side effects to be detected before travel so that possible alternative can be considered. Okay, what drug is that? Weekly mefloquine. Okay, so this is something new that I told you in the presentation, so you all can remember that this is used in prophylaxis, and it is something should be given started 2-3 weeks before departure so that side effects, if any side effects are there, they can be treated before they travel. Okay, or if any alternative can be considered. All prophylactic drugs should be taken with unfailing regularity for the duration of the stay in the malaria risk area and should be continued for 4 weeks after the last possible exposure to infection, since parasites may still emerge from the liver during this period. Okay, so this is a picture that I took from this project No Fever that is going on nowadays. If you'll just type this in the Google, also you'll get information on this, and there is some Telegram and WhatsApp contact number where the people at this program is encouraging or involving the people from the gated communities or communities, the school children especially. They are inviting school children so that they will actively participate in this, so that they will try to um uh, you know uh, kind of giving a health education to others, and to do some campaigns in their communities, and to do these small artemivores and then spraying they will give small videos where you can prepare your own solution at home. So this is going on right now. This is the latest program going on outside in the in cities of in places in Hyderabad. So yeah, mosquito breeding sites. So mosquitoes is just a teaspoon of stagnant water to breed. Any untreated stagnant water around your homes can encourage mosquito breeding. So these are the example they give: empty containers, ponds, swimming pools, untreated water, storm drains, overwatered plants, unchanged pet bowls, empty planters, old tires, and there are many other examples like paper cups. Paper cups after drinking tea or coffee, coconut shells, uh, and flower vases outside or inside your home. All these are mosquito breeding sites. Okay, since monsoon is upon us, we need to ensure that the areas surrounding our homes are free from unnecessary stagnant water, and in areas where stagnant water is unavoidable, ensure to treat the water as required. Okay, so that is it for today, and thank you so much for listening to the class. Okay, have a nice